Returning to behavior theory, when the last tape left off, we were talking about the ideas of acquisition and extinction of behaviors, and about internalization and generalization. So sort of important concepts around kind of this idea of how is it that we learn. If you look at the acquisition of behaviors, we've come to appreciate that some things are very quick to learn. So when I talked earlier about flying on an airplane and eating peanuts at the same time as bopping along the clouds and starting to feel airsick, that's called conditioned aversion, and that will people acquire very quickly. And they believe that that's a result of the fact that biologically it's important if you're living in the wilderness and you eat something which is toxic, and hopefully, if you're lucky, it will make you very sick, and you learn to never eat that again. If it takes you 30 times to learn that, you may be very dead before you have an opportunity to learn, don't eat those mushrooms or those roots or something along those lines. Other things take a lot longer. It took Pavlov's dogs many more trials than that to learn to salivate, to begin salivating to the tone. So some things are easier to acquire, some things are harder to acquire, and that's important to appreciate as you're working with people. Extinction, what we find is that oftentimes the best way to extinguish something which has been learned, if we're talking about classical conditioning, the best way to extinguish the response is to have the dog stay in the same situation, have the tone, and no meat pattern. So you pair this non-biological stimulus with, you do the non-biological stimulus, but you don't provide the natural stimulus, which is the meat powder, and eventually, after hearing bell after bell after bell and getting no meat powder, the dog should forget or should no longer have this connection between meat powder and bells. That works sometimes. The dog will forget. The thing is, there's what's called a savings, and so if the dog ever again hears a bell and is fed in close succession to one another, it comes back much more quickly. So if you've forgotten something, it just comes back faster than it did, and that's called savings, and they now know the sort of neurological mechanism for that in the brain. So that's an extinction which might sort of be a natural extinction. When clients come into therapy and they often have this fear reaction, it becomes more problematic because what happens with the person who drives by Safeway, and every time she drives by Safeway after the accident, she has some sort of panic attack or some sort of very scary response. What's the natural thing to do if driving by Safeway makes you terrified? You find another route home. If you have someone who's been sexually abused as a child and the abuser had been drinking prior to the abuse, and there were many pairings of the smell of alcohol on someone's breath with the abuse, you may have someone who, if he or she goes out in public as an adult and smells alcohol, they just have a horrible response because there's this pairing of the smell of alcohol with the abuse. So what do? They may stop going out in any public places where anybody who's there may have been drinking because they want to avoid this scary thing, or they want to avoid this bad reaction from happening. Well, once you start avoiding it, you don't allow extinction to occur naturally. You're not in a situation where you can smell alcohol on someone's breath. For example, I was at a movie a few weeks ago and people sitting right behind me had quite apparently been drinking. If I had a bad reaction to that, then I would have had to have walked out of the movie or never gone out to the movies in public. So you can see why people will want to extinguish some of these responses. It would be a nuisance to have to not drive home past Safeway if that's where you live. But because we avoid it, we don't have the opportunity to keep driving by Safeway and realizing the odds of having an accident there are very, very, very slim. I can safely drive by Safeway. But because you don't go through the motions again, you just stop and avoid, it stays stuck. And so one of the things therapy does is what's called systematic desensitization. And systematic desensitization is therapeutically giving people the tools they need and taking them with baby steps back into the scary situation without having the scary thing happen. and giving them relaxation tools and exercises so that they can cope with the situation a little bit at a time and realize this is not so terrifying, and consequently can sort of get back on with their life. Again, internalization and generalization, this is what you've learned because there were these careful antecedents and consequences in place, you may actually take with you out into the world. So a big thing here is if you have kids who are in a special education classroom where the teachers have very tight control of their behavior. But the idea is then to mainstream the child back into the regular classroom. Well, has that kid learned through, lots of reinforcers or whatever sort of ethical punishers, if the school has punishment, whatever ethical ways the school has to punish the child, has the child learned to do what they need to do to survive in the mainstream classroom and not to do some of the sort of antisocial behaviors that they were doing which don't work in school? Have they learned that sufficiently so that when they go back and there's one teacher for 25 kids as compared to 2 teachers for 8 kids, that they can function okay? Or once they go in the more relaxed environment of the mainstream classroom without this tight situation of reinforcers and punishers, does their behavior just kind of fall back and they have to go back into the classroom where there is very tight environmental control again? So this is where this stuff really becomes important, because you hope if somebody comes into a treatment center, goes for therapy, goes into a special classroom, goes into a residential treatment facility, that when their behavior comes in line because you have this very tight control of antecedents and consequences, that it becomes sort of who the person is, that they take it with them, they internalize it, instead of just, I can behave here, but as soon as you put me back there, they kind of just fall right back down, entropy takes over again. So if we look at, so what does the therapy look like of behavior therapy? How do we apply these principles to working with people? 2 things, as you can probably guess. This is a model where you as a practitioner will be active and you will be directive. So it's very non-Rogerian. You do not sort of just become a warm, empathic individual and listen to the client and watch them grow. You believe that you have tools, you have things help humans to sort of change their behavior, and the client comes in and you're going to offer these tools and sort of help them to set up their world in such a way as that they can live more effectively. The one place I was reading had a nice way of describing this, and they talked about the client will come into the session telling you what it is that he or she would like to see different. You, the therapist, will help the client with how they can do that. So the client chooses what to change. You, the therapist, help them develop tools and techniques to actually bring about that change based on your knowledge or expertise of behavior therapy. It used to be kind of this myth that all of behavior therapy was in the tools and techniques, and you had such powerful tools and techniques that if you were the most warm, loving person on the planet, if you were just a rotten individual, it didn't really matter, because what mattered was the tools. Well, what we've come to appreciate is that whatever model you are working in, your connection with your therapist really does make a huge difference. And so a behavior therapist who is warm and interesting and engaging and caring and concerned about his or her client is a far more effective therapist, even if they use the exact tools and techniques as the person who's distant and cold and detached. So behavior therapists these days fully appreciate the benefits and the purpose of establishing a good, healthy relationship and genuinely care about their client as much as any other model. But there's kind of just this bad taste in people's mouth that this is a mechanistic thing, it works on rats, it works on pigeons, and it's really not a very kind of loving, nurturing environment. That absolutely does not need to be true, and in the vast majority of cases it's not true. It's kind of just this bad piece of the history. So this is your work with the client. What are the kinds of issues, concerns, and so forth? This stuff works very nicely where you have a high level of control of antecedents and consequences. So with your adult outpatient who comes in to therapy, they can set up their world in such a way, and you can do the skills training, because skills training is definitely big here. And that probably for adult outpatients is one of the biggest general components of behavior therapy that you'll do, is some sort of skills training, helping them learn communication skills, or helping them to learn parenting skills, or helping them to learn job seeking skills, or all those things that I talk about as well in cognitive behavioral. Other things that people will use behavior therapy for are very specific targeted problems. So systematic desensitization is one of the main tools used when people come in with fears and phobias. Systematic desensitization is a series of baby steps paired with relaxation skills and exercises to help people to face situations which they formerly couldn't face because they were terrifying to them. Flooding is another behavioral technique used, but flooding, instead of being little baby incremental steps towards conquering your fear, as kind of like thrust people in a situation, fill the situation with scary stimuli, and kind of hope for the best. That the person will overcome the fear because they realize that what they think is so terrifying really isn't so terrifying. Stress management, time management, all those kind of things which could fall sort of under the topic of skills training are used a lot with adult outpatient, sort of fairly functioning individuals. This stuff is also used a lot in settings where it's some sort of residential, either short-term or long-term setting, where the agency, the school, the institution has a lot of control over the environment, because this is a model which says if you change the environment, the person will adapt to a different environment. So, parenting. Parents, particularly with young kids, have huge control over their children's environment. And so I've taught a number of parent education classes, and if you look through parent ed books, a huge number of the tools that you help parents to learn to raise healthy, functioning kids come from behaviorism, and in some way, shape, or form incorporate the ideas of, if not classical conditioning, certainly operant conditioning in terms of reinforcers and punishers. Generally speaking, we really try to focus on reinforcement. It works better and is ethically far less questionable. Punishment doesn't seem to work as well. People learn to be sneaky, to engage in the behavior they want to when nobody's watching, and not to engage in it when people are watching. And there's some ethical concerns about a lot of punishment that you might have. So operant conditioning with a stronger emphasis on reinforcers and the idea of modeling. And I can remember a friend of mine who was a nurse working for a behavioral unit one time, standing there talking to me. She's holding a cigarette, and she's saying, you know, you work in quit smoking clinics, Heather. What do you think would be the best thing I could do? My 14-year-old daughter just started smoking, and it really bothers me, and I can't figure out how to get her to quit. And I looked at this friend of mine, and I stared at her cigarette, and I looked at her, and she says, oh, well, anything but that. Well, that's modeling. I mean, we know that kids where mom and dad smoke have a much higher probability of smoking than kids where mom and dad don't smoke. So the best thing mom can do if she wants her daughter to quit is to model that she can do it by quitting herself. So things like that have been incorporated into parenting, as well as things like communication skills, particularly for teens, how parents can communicate in a sort of healthy, active listening, give your teenager a chance, they're not 2 years old any longer kind of fashion. Schools eat this stuff up. While reality therapy, choice theory, Glasser is to some extent in schools using his model, many more schools adopt a behavioral approach. My experience in the schools here locally in Walla Walla are that K1 through 2 in the public and private schools pretty much run on some kind of what's called a token economy. If you read about a token economy, a very structured token economy is one where any little behavior you engage in, you get something for it, you get something taken away. You really try to have very tight control of the people in the token economy. Well, classes run in a more relaxed form of that, but certainly when my son and kids and friends of mine were in the younger grades, you know, kids got tokens for doing specific things, and they lost privileges for doing other things, and they either moved a car, or they went to, you know, if you got so many tokens in a week, you went to the box and you got to pick a little toy, and if the class was good enough each day, they'd put a marble in a bin, and when the bin filled up, they all went out for ice cream, or they all went roller skating, or they all went swimming at the Y, or something like that. Those are behavior modification. It's bribery, if you want to call it that. It's using an incentive, if you want to call it that. But it's a form of encouraging, or to use the less favorable term, manipulating others to behave in order to get something that they want. The thing about using a reinforcer is you have to have a reinforcer which is meaningful. If you want kids to all behave in the classroom in order to go roller skating, if you have a couple kids who hate roller skating, their level of motivation is not nearly as high as the kids who are just itching to get in the roller rink with all of their classmates. But schools are a very, very big place for implementing behavioral models. Residential treatment facilities for kids, for teens, adults, we don't generally call them residential treatment facilities for adults, we call them things like psychiatric hospitals or prisons, but psych hospitals and prisons will often incorporate token economies or some sort of BMOD system to help. Nursing homes occasionally will adopt some sort of behavioral modification for their residents. In agencies with people with developmental disabilities, in group homes, to help families who are living with family members with serious developmental disabilities. There's a lot of behavior modification of finding out things which are reinforcing, finding out things which will encourage good behavior, which we can use so that if you do this, then we'll do that. Sometimes that's a very powerful way to sort of encourage behavior among people with developmental disabilities, and occasionally people with serious mental illness. The first token economy was done in around the late 50s or early 60s, and was done on a sort of, you know, back in time unit with people who were very seriously psychotic. And the two psychologists went in and they ran this whole token economy, and they got these folks who were doing practically nothing day after day after day to really get up and brush their teeth and brush their hair and go to breakfast and sit in the day room and maybe occasionally talk with one another or play checkers or, you know, play chess with the staff or something, and really bring their level of behavior up much better just by sort of giving them good things for doing things that they wanted and taking away privileges and so forth if they did things that they didn't want. Well, the sad thing was that the two psychologists who ran the study, I think it's Azrin and Schifrin, when the study was over, they said, hey, we've learned a lot. Aloha. And they left. And the hospital unit didn't do anything to keep in place the token economy system. The psychologists left. Within a couple months, the behavior of those inpatients was right darn back where it started. That's a classic example that it really didn't internalize. Even though looking from the outside, it looked like the lives of those patients was so much richer and more meaningful, and their days were so much more filled with doing something. It was not internalized. As soon as you took, you know, the goodies away, the behavior went right back down. And that led to a lot of ethical debate. And those of you who are interested in the history of behaviorism can read about the ethical debates of the 60s and 70s. And are we turning humans into robots or humans into animals? And are we taking away free will or free choice by just paying them, you know, for doing things with antecedent and consequent control? And it was a huge issue. And anyway, okay, I guess those are the majority of applications. This is an alive and well model. It has, for a large part, been incorporated with the cognitive behavioral, which is, as I talk about in that class, probably the most alive and well, if you want to look just in terms of sheer numbers across the globe, model being used today. And so most clients who will come in for therapy, if you're a behaviorist, you will also incorporate some of the cognitive tools, because behaviorists have come to appreciate that in addition to being acting, doing things, we really are sentient, thinking individuals. But all of this incorporated with cognitive stuff really does make for some pretty powerful changes in terms of what people do, as well as in terms of how people look at themselves and think of themselves. And that's it for behaviorism.